Okay, this is video 2 of the circulatory system. Just to go over these labs a little bit, you know what an EKG is. That shows the cardiac rhythm. Um, we will talk about that more in class, and we will really learn how to read an EKG, the basics of it, again in 102. But it shows the cardiac rhythm, which is the electrical circuitry of the heart. A chest x-ray can show if a heart is enlarged, if there's any kind of pulmonary congestion, um, if there's a valve that's calcified. Sometimes that will show up on a chest x-ray, but it'll give the basics that there might be a problem. An electric echocardiogram is probably kind of the first line after an EKG of how they look at the heart, and it shows the chamber size, any hypertrophy. You will see valve dysfunction because you'll see the blood backflowing. This is where they figure out the ejection fraction and if there's any kind of regurgitation. Exercise tolerance tests are done with what they call a stress echo. So they'll put somebody on a 12-lead continual EKG. Then they'll stress the patient watching. They'll put them on a treadmill, so you're running and running, and they're watching your blood pressure, they're watching your heart rate, they're watching your cardiac rhythm, and then at some point in it, when you hit a certain point, your cardiac rhythm is stable but high. Then they kind of lay you down really quick, and they do an echo of your heart when it's moving really fast, so they can see how stress impacts the valve. It's a very, very definitive test for any kind of cardiac problem. Then you keep pumping that up, and you can add some radioactive dye, and that helps identify the ejection fraction just a little bit more, and also what the valves are doing. Then angiography can be done, and this can be done using dyes. It can be done using a cath, and basically what it is, it's taking a radioactive dye, injecting it into the vessels, and watching it go through the heart. And it shows pressure changes. And again, the radioactivity shows up via X-ray technique much better than it would without the dye. Early detection of any kind of cardiac event, of course, is the most important. So you always want to make sure that you're being definitive when someone has chest pain, nausea, and we'll talk about all those signs and symptoms later, but this gives you an idea of where you're going to go as far as testing. On to the next slide. Here are the basic lab values. Again, these are lab values that are going to come up over and over again. CKMB, this measures muscle damage. It's not specific to cardiac muscle, it's specific to muscle damage. So you could break your ankle and your CPK-MB would elevate. But what it does, it's based on the time of the damage. So it starts to give the care provider an idea of when the heart damage started. Troponin is muscle damage to cardiac specific muscle. So this is the telltale sign if there's been a myocardial infarction. You want troponin on a normal person to be under 0.1. I've seen 37 before. Obviously that person, and they survived. It's amazing, but most of their heart was damaged. We were able to cath, get in there quick, and the person was okay. But you know, when that happens, your heart will never be the same. Lipids and cholesterol, this is really important because if you keep your cholesterol, your LDL low and your HDL high, you can avoid a lot of cardiovascular issues because cholesterol will not build up in the vessels. CRP you see sometimes, not very often. PT and INR and PTT have to do with anticoagulation factors. Again, here's a few more ideas on testing. Just explains it a little bit more. Cardiac cath, do yourself a favor and get on YouTube and look up a cardiac cath. There's bazillions of videos. And you can see on the videos how they're done and what kind of things they're actually looking at within the heart. A thallium scan, again, it looks for cardiac ischemia. They inject thallium, and if there's a blockage, the thallium will not perfuse through the vessel, and that's how they can tell if there is some sort of an issue. Big thing when you're doing cardiac cath, of course, for us as nurses, is we want to be able to educate the patient on how it works, and we want to know how to do pre and post-op cath for the patient. This slide gives you all of the basic information. And again, please look up a video. You can see cardiac caths that are done through the groin, which is normal. It's a femoral artery and femoral vein. And now they're starting to do them in the arteries, the brachial arteries, and the radial arteries. So really some amazing advances. Things that used to have to be done by open heart surgery can now be done with a cath, which of course is far less invasive. When someone has a cardiac cath, let me just add this. This is what you need. Informed consent. You need to check for allergies, especially to iodine and dyes. They have to be NPO. We have to educate them. The patient will be under conscious sedation. They want them awake because they want to be able to ask during the cath when they're doing things if it causes chest pain or pressure. And you have to let the patient know when the dye is injected that it's going to make them feel flushed, especially any mucous membranes will feel very hot. Also, then there's post-op care. A cardiac cath is done through the groin usually, and we'll talk about more of this later, but post-op care requires putting pressure on that site. The patient will be asked to stay flat, so no pressure is put on that artery for a couple of hours. So cardiac caths are done for sometimes just investigative purposes to see if there is some sort of valve issue. They can see that on a cath now. Obviously with MIs or any risk of blockage, they'll do a cath. But what you're going to see a lot in the population you're going to be caring for, especially in nursing homes, aging people in the office, that kind of thing, are people who have hypertension. And hypertension, if controlled, people can live long and healthy lives. But if it's out of control, hypertension can cause all kinds of issues, cardiac output issues. It can cause left-sided heart failure, which will lead to congestive heart failure. It can cause all kinds of different issues with the eyes and with the kidneys. So we want to do what we can to avoid hypertension. And this slide basically gives you the idea of what a normal blood pressure is, what pre-hypertension is, what stage 1 is, and what stage 2 is. And then, like I said, hypertension can affect so many different areas of the body, specifically the kidneys. It can make tumors of the adrenal glands, aggravate them or make them worse. Sometimes it'll be if there's an adrenal issue that causes the hypertension, and then that just aggravates it. Blood pressure is determined by cardiac output, peripheral vascular resistance, and it's the ability of the blood vessel to stretch, the blood viscosity, circulating volume. All kinds of things will affect whether someone has a blood pressure issue. Hypertension is the silent killer because it does not cause any pain. So you need to remember that, and you really need to educate your patients that even if they're feeling well, they still have to take their medication. It's a lifelong thing. Quite often there are absolutely no signs or symptoms. Obviously, if they're getting regular checkups, they'll see the increased blood pressure. When it gets to be severe, sometimes they'll get headaches, bloody noses, high anxiety, shortness of breath. It just depends on the patient, but the biggest thing you have to remember is normally it doesn't have any signs or symptoms. Now, we've talked about this before, but with hypertension, there are modifiable risks and there are non-modifiable. Non-modifiable are things you cannot help. You cannot help that you're a girl or a boy. You cannot help how old you are. You cannot help if you're black, white, Hispanic, American Indian. None of those things can you help. You cannot help that you have diabetes. However, you can manage diabetes. So even though diabetes would be a non-modifiable risk, it's modifiable in the fact that you can manage it. So that one's kind of a misnomer, sort of. But what is modifiable? Well, if you modify your diet, for some people, you might not even have diabetes anymore. If you're type 2 and you're, 80 pounds overweight, you lose that 80 pounds, you probably will not test positive for diabetes anymore. What's your activity? What are your glucose levels? Do you smoke? Do you not smoke? How much salt do you intake? How much alcohol do you drink? How much do you sleep? If you sleep less than 5 hours, you have a higher risk for hypertension. So the first thing we want to do when we diagnose a patient with hypertension is we want to help them make lifestyle changes. Almost always, the patient's going to need to lose weight, unless they have some sort of genetic propensity to hypertension. I currently have a friend who has hypertension and she only weighs 130 pounds. And you would think by looking at her blood pressure that she weighs about 300 pounds. It's been very frustrating for her because she cannot control it with her diet. Okay, again, making lifestyle changes is very important when you have hypertension. Weight loss, exercise, very important. Then there are medications. In your Williams and Hopper book, there is a pretty good list of the medications that treat hypertension. And the following slides, you just want to fill these out. But even better than filling these out would be to make med templates for each classification, because then you'll have them. But let me just go over them real quickly. Thiazide diuretics, some people call them water pills, and they take the water out of the blood vessels, reducing the blood volume, reducing the blood pressure is basically how they work. Loop diuretics, they also work in the kidneys. This is, loop diuretics take away potassium though, so you have to be very careful. The number one loop diuretic is Lasix, which I'm sure you've heard of. So when people on Lasix, you really have to watch their potassium. Next group is beta blockers, and these medications reduce the workload of your heart, open up the blood vessels. Your heart usually beats slower and more efficiently. Angiotensin converting enzyme inhibitors, ACE inhibitors. These drugs relax blood vessels, and sometimes, especially if you have a chronic kidney disease, an ACE inhibitor is a pretty good drug. ARBs are medications that relax the blood vessels again. They work a little bit different, work on a different system. And also they help a lot with people who have chronic kidney disease. So again, here's several slides of the main classes of drugs that you want to know, and I'm not going to go through each one because you know how my feeling is about that, and you need to actually look these up, write them down. I would use you could use these slides, but I would probably make med templates for each class using the ATI template. I think that would be a better thing. All right, so as nurses, what are we going to do for hypertension? We're going to monitor the heart rate and blood pressure, educate on side effects, on taking medications, on electrolyte imbalances. Some medications cause erectile dysfunction, and then again complications. I'm going to finish this video. This is video 2, and go to the next video and we'll pick up on this slide again.